Good morning to all. My topic presentation is retinal nerve fiber layer alterations in migraine, a comparative study. Introduction. Migraine, we all know, is a common disabling neurological disorder characterized by recurrent headaches. Its effect on brain structures are very well established. Evidences that it may impact the RNFL layer is also being growing nowadays. Migraine mechanisms that alter the RNFL is one is vascular dysregulation, other is inflammatory changes. RNFL alterations may act as biomarkers for migraine severity. It is also a risk factor for normal tension glaucoma. OCT gives a precise measurement of the RNFL thickness. Aim is to evaluate the structural impact of migraine on RNFL thickness using OCT. Materials, it is hospital-based study, descriptive comparative study for the period of 2 months. Patients were taken were aged between 18 to 50 years. Consecutive sampling was done, and the participants were divided into 2 groups, 60 in each. We included all the migraine patients who were diagnosed by a neurologist according to the ICHD3 criteria with or without aura, and all the healthy controls were also taken without any ocular or neurological diseases. Exclusion criteria, we excluded secondary headache, optic disc edema, patients' structural brain lesions, glaucoma, and retinal pathology. First, we took informed consent followed by detailed history taking. Then, ophthalmic evaluation was done. RNFL thickness was measured using a spectral domain OCT. Results. First is comparison of background characteristics of patients with migraine and normal population. So this is age and sex distribution which is showing. The mean age of migraine patients were found to be 38 plus or minus 11.6, and of controls were 33.8 plus or minus 10.3 years. In both migraine group as well as the control group, predominantly it was females. Coming to distribution of characteristics of migraine among the patients with migraine, that is, we took with aura and without aura and also the duration of migraine. And we saw that most of the patients who came to our OPD were without an aura, and only 21% had aura. The mean duration who came to our OPD was almost 8 to 6 months, 8 months, and only very few patients came with more than 1 year. This is a comparison of RNFL thickness between patients with migraine and also the control group. Here's another chart representation. We all compared all the 4 quadrants, that is superior, inferior, nasal, and temporal, as well as global RNFL. Thickness was compared between both the groups. And we found that there is a significant thinning that is seen in the RNFL layer in most of the quadrants, especially in the superior and the inferior quadrants of migraine patients as compared to the controls. And this is based on the type of migraine. But in type of migraine showed no significant difference between control as well as the migraine group. And discussion. Migraine is associated with notable structural alterations in RNFL, which reflects the underlying neurovascular stress. The RNFL difference, significant thinning was found in superior as well as the inferior RNFL quadrants. In most of the patients, p-value less than 0.01, suggesting that these regions are particularly vulnerable to migraine-related vascular injury. And quadrant specificity, the nasal and temporal quadrant showed very less, that is, inconsistent differences in both the groups. And based on the aura status, our study showed that did not show any significant difference between migraine with or without aura, which show that aura is not a major determinant in RNFL structure involvement. Overall pattern, superior and inferior RNFL thinning indicates localized axonal loss, likely due to recurrent vasospasm. Role of OCT. OCT detects a subtle optic nerve changes even in early migraine, so establishes OCT as a highly sensitive early diagnostic tool. Conclusion, migraine patients showed significant RNFL thinning on spectral domain OCT. Superior and inferior quadrants were mostly affected due to neurovascular vulnerability. RNFL loss was independent of aura and migraine duration. Findings suggest that recurrent vasospasm and hypoperfusion as key mechanisms in retinal damage in migraine patients. Migraine-related RNFL thinning may increase the long-term optic nerve vulnerability, similar to glaucomatous patients. So OCT is a rapid, non-invasive, highly sensitive tool. Future studies can be done combining OCT with visual field testing also to assess the functional disability of the patient. So limitations of our study, as it was a pilot study which I conducted, it was a smaller size, sample size, and only very short duration patients were included. So we couldn't assess the long-term effects, and only RNFL was assessed. No functional testing was done. Thank you.
You're told about aura, no? What type of aura the patient had? Some of your patients, some percentage of got aura, no? Aura.
Yes, sir. So actually, they were diagnosed with aura. The patient actually had visual aura symptoms mostly. Most of them visually and yes, sir.
What type of this thing, visual aura?
So they could see things. They were telling like floaters, maybe lightings, like flashes of light. That was one of the
fortification spectra you've seen.
yes, sir. Like they. So mainly ocular symptoms, ocular aura symptoms, sir.
Those patients didn't have any problem in the.
So actually, with the aura patients, it was a consecutive sampling. So we only got with the aura patients very few in number. So that is one limitation, sir. So we can, so in my result, most of them were without aura. So that is why the result came as without aura. There is no significance. Maybe if you take more patients with aura and if you do the future study, maybe we can find there will be some associations. That is one limitation of my study, sir. Very less sample came with the aura. That's the.
You are a postgraduate student.
Yes, sir. Yes, I'm a postgraduate.
Which college?
Pariyar Medical College.
Okay, can I ask you one question?
Yes, sir.
What is Tichopsia?
Sir?
Tichopsia. Tichopsia. Because we are starting about talking about migraine. This is some type of viva question we'll ask you in exams. Of course, doesn't matter about this paper. What is
Not
Tichopsia? Tichopsia.
Not sure, sir.
If you tell correctly, Rashidhar, got it? You don't know. The
No,
other
sir,
name
sorry.
for fortification spectra. You are getting, aura. That
Yes,
is
sir.
called Tichopsia. Okay.
We appreciate the thought, but as you said, the progression of the RNFL defect we haven't established.
Yes, sir. Yes, sir. It was,
So the association between an RNFL defect, a standalone RNFL,
Yes.
presumed RNFL defect, in a patient who is presumed with migraine. Migraine
yes.
is also not a definitive diagnosis.
yes. Yes.
I haven't seen neurologists give migraine as a definitive diagnosis. It's just a sort of a wastebasket diagnosis where they couldn't make any other diagnosis, they'll bring to this diagnosis. So those kind of variables are still there.
Yes.
But the thought is correct. At least in these kind of patients where you say that vasospasm is
Vasospasm is
a
a major
recurrent
factor.
factor, then how much it affects the disc and RNFL is good to see. And obviously do it with field and do it with
Yes, sir.
MFERG
Functional
also.
assessment
You
was
can use
needs to be-
MFERG on those spots where
Yes,
you
sir.
suspect
Yes.
the RNFL weakness, and that points can be revealed
Yes, sir.
by that. Good.
Last point.
Yes, ma'am.
In migraine, there is spread of cortical depression. The cortical matter what is affected. So more than RNFL, I presume GCC would be a much sensitive marker
Yes.
in migraine patients.
Yes.
And ideally, whatever the migraine, whatever visual hallucinations, positive or negative, they never cause a permanent visual defect. And I hope you've ruled out all retinal migraines in these patients. Okay? Because their thing can be different.
Okay. Thank you, ma'am.